Nutritional and food requirements of preschoolers. Those who have the dietetics textbook, it's chapter 5, page number 84 in old textbook. It's page number 88 in new textbook. If anyone is joining late, please help them out with the page numbers or the topic name, whatever we are discussing at that point of time. So we'll start with today's session. Nutritional and food requirements for preschoolers, preschool children. So 20%, approximately 20% of the Indian population come under the preschool category, okay? And out of which the growth, the maximum, these are the years like 1 to 6 years of age, okay? This is the growth years, which is lower than what they have seen in their infancy, okay? But it will be much rapid as soon as the child ages up to the time when they become school children, okay? That is a specific time when the energy demands are becoming quite high, okay? Because of the activities that children are involved in school and other extracurricular activities that children are involved in, energy requirements are quite pronounced when they transition from the preschool age to the school children age. So the most challenging situation in this particular age group is establishing a healthy childhood feeding habits. Okay, the kids here throw a lot of tantrums of eating. Okay, they are very picky eaters. Most of the kids in this particular age group, they are very picky eaters. Okay, parents have to run behind to feed them to make sure that they are well nourished, etc. So the main challenge here is to make sure the child has good relationship with the food, and they upon that they practice good eating habits as well. Okay, so there is a marked increased need of all the nutrients, and the pattern of nutrient increase will also change with relation to the growth that the child is achieving. Okay, the more active the child is, definitely the energy requirements will be quite pronounced. Coming to the nutritional requirement, so more or less it is very similar if you compare the old ICMR data and the students who have the old textbook. You have the ICMR data of 2010. Students who have received the new textbook, the ICMR data which is mentioned here is of 2020. So the difference is a decade-long difference. Okay, what changes? It is not very much pronounced. Slight increase in calories are there. Slight increase in energy requirement, protein requirement also. They have shown a certain decrease in protein requirement as compared to the old data. Okay, so if you just search on internet about the ICMR recommended RDA requirements for preschool children 2020, you will get the same data which is available in the new edition textbook. Okay, those who have the old textbook, it is 2010 data. New textbook has the 2020 data. Okay, so slight differences here and there. It is not much pronounced. It's very minute differences are there in the RDA values. Okay, so we'll go by the old textbook details for those who have the old data. And if you want to check the new data, check ICMR 2020. Okay, RDA for preschoolers for 2020. You will get the same. Value. Okay, so energy requirement is around 1060, which is mentioned in the old textbook for children who are 1 to 3 years of age, and 1350 as soon as they grow up, as I mentioned, when they are transitioning from preschool age to school children age. Energy requirements will be quite pronounced. Okay, and your diet has to keep up with energy requirements, otherwise it will affect their growth and development. And when you compare it to the new textbook, a very minute difference. Okay, energy requirement for children who are in 1 to 3 years of age, according to the new data, it is 1110. Okay, KCL. And for 4 to 6 year old child, it is 1360. Just 10 unit difference in the calories is given. Okay, so difference is quite minute, but the range is almost the same. If you take the range of values, it comes under the same range of values. Protein requirement, it is 1.3 gram per kg body weight. And if you go by the protein requirement of the toddlers means, when I use the term toddlers, it is 1 to 3 years of age group children. Okay, 1 to 3 year old is considered as a toddler. Okay, for them 1.3 gram per kg body weight is adequate. But when the child grows a bit, 4, 5, 6 year old child, it is ideal they follow a 16 gram per kg body weight. Okay, visible fat, 25 to 27 gram per day that you can maintain. Okay, at least 25 gram. At least 25 gram should be there. Page number in new textbook is 88. So visible fats, 25 gram. Even for like for a regular adult woman, 25 gram of visible fat per day. Adult sedentary woman, 20 to 25 gram is ideal. Okay, and that is what we will follow for the kids as well. 25 gram, at least 25 gram per day. And if the child is active, hyperactive, only then you can add more. Okay, up to 30 gram also you can add, but limit it. Okay, if you are limiting your child's introduction to junk food, deep fried food, okay, in that case visible fat you can use up to 30 gram. But if the child is habituated to having a lot of junk food, okay, packaged food, usually kids in this particular age group tend to go towards that direction as well. Okay, they don't want home cooked food, chocolates, soft drinks, some bakery items, etc. This is what they favor a lot. Okay, so if the child is indulging in a lot of junk food, you have to keep the visible fat up to 25 only, not less or more than that. Calcium requirement 600 mg per day, but according to your new textbook, it is around 500 to 550 mg per day. Okay, 500 to 550 mg per day. According to the old textbook, they have mentioned 600. There is a difference now in the new data, but the range is almost 10 micrograms above and below. It is completely fine. Okay. Iron requirement 0.2 to 0.5 mg per day. Iron requirement in the new, according to the new data, okay, there is a slight change. It is reduced. Okay, the old if you have the old table, it is slightly increased. It is reduced by 1 unit. Okay, for toddlers it is 8 mg per day, and for 4 to 5, 6 years old, it is 11 mg per day. Okay, in the old textbook they have given 9 and 13. It has slightly reduced in the new RDA. Vitamin A, 400 microunit is the safe limit. Vitamin A, you have to be very careful. Whatever happens, the child should not be deficient in vitamin A. It will affect the if it is fine, I take the class without video today. Maybe there is some network issue. Is my voice audible? Yeah. I guess there is some network issue. I'll keep the video off. It won't be distracting to you. Okay. So vitamin A, 400 microgram is a safe limit. Vitamin A, you have to be very careful that even see the range which we can use for 1 to 6 year old is about 390 microgram to 510 microgram. So 400 is something sandwiched right in between that we can use for both these age groups. Okay, so vitamin A deficiency, you have to be very careful. It will affect the eye health of the child. Okay, if the child has been vitamin A deficient for a prolonged period of time, it could lead to night blindness, loss of vision, etc. We will come to that later. Okay. B vitamins, or vitamin B complex, based on the RDA chart which is given, you can just refer that. No need to by heart anything from B complex vitamins. The child, if the child is having enough amount of pulses, cereals, multigrains, okay, millets and groundnuts, peanuts, anything that is made of groundnut and peanut, if the child is having peanut butter jam sandwiches, okay, at least thrice a week, if the child is having, your vitamin B area is covered. Okay, vitamin B will be covered. Vitamin D, very important. Exposure to sunlight, at least for 5 minutes. Encourage the kids to go out and play rather than giving them the smartphone, iPad, notepads, and letting them sit inside the home and be in these devices. Okay, encourage the children to go out and play. At least 5 minutes of bright sunlight exposure. Bright sunlight exposure, which means specifically if you do not have time to spare. Okay, if you do not have time to spare, only then 9 a.m. to 2 p.m. In that particular time period, 5 minutes of exposure to sunlight. Okay, wear loose fitted clothes, light colored clothes. Okay, and expose the children for 5 minutes to bright sunlight. That is the peak hours. Okay, if the child has a habit to go out and play, okay, has a habit to go out and play, you can take away this particular bright sunlight time period, and you can either encourage the child to go out and play in the evening, that 4 to 6 p.m. 4 to 6 p.m. is the ideal time for the kids to get out and play. The sunlight is not that bright, but the vitamin D exposure to sunlight is enough for vitamin D synthesis within the body. Okay. So outdoor physical activity is encouraged and suggested by the expert committee of ICMR as well. It depends on, see, 9 a.m. to 11 a.m. is usually the time when kids, if they are going to some Anganwadis or if they are enrolled in play schools, okay, these are the time periods when they are inside the play school, okay. But when you are extending that hour, when the parents are going to get the children from the play school and all, so that's the reason why 9 to 2 a.m. Around 2 a.m. also you have a really bright sunlight, okay. We'll come to the sugar intake. We'll come to the sugar intake and its association when it comes to the tooth decay and problems associated with dietary complications associated in this age group. We will discuss that. Usually, the sugar intake should be around 20 to 25 grams per day, not more than that. Okay. And it is very difficult to if it is very difficult to track this in kids, you do not have to worry much about the sugar intake, but to track the exact sugar intake among kids, it is difficult. Okay, they go to school, they get chocolates, somebody's birthday celebration, okay, they may have cake, birthday parties or something. Okay, they kids have more exposure to receiving something sweets, okay, from family, friends, school, okay, anywhere. Wherever you go, you definitely invite a child with some sweet or something. It is very difficult to track, but the amount of sugar that you use in the diet of the child, that is something that you can control. So don't go beyond 20 gram. Okay, 25 gram is what WHO and other health organizations has limited for a sedentary adults intake, but for children 20 gram is fine because they are having additional sugar intake from so many other sources. Okay, so 20 gram upper limit you can keep for the sugar that you use at home for cooking purposes. Okay. Coming to the food guidelines, dietary guidelines, parents are completely responsible when it comes to what kind of food you offer to your child, what kind of cuisine you prepare at home. Okay, are you investing your time in making sure that the child has food at right intervals? Okay, this is how you create a feeding pattern. Okay, because naturally by that time, within, if you follow this for a week or so, by the next 7th day or 8th day, by that particular time period, the child will get hungry. Okay, the child will ask for food. A positive relationship with the food will be maintained. See, not just orange, and any citrus fruit which is abundant in vitamin C is quite good for the children when they're going through cough and cold. Okay, vitamin C enhances your immunity. Okay, and specifically for kids who are Kids usually get a frequent visits of infections, so that vitamin C intake has to be adequate. Okay. Don't give the cold orange. Don't give cold orange or cold fruits. At room temperature, fruits can be given. And usually it is seen that some studies have shown that children have this ability to self-regulate their energy requirements. Okay. Studies have found out that when parents, when they try to force feed or bribe their children to eat, okay, you will say that, okay, if you finish your food today, you've finished the plate clean, I'll give you this chocolate, I'll give you cake, I'll make this for you, I'll take you to the park or something like that. That is the bribery. Okay. When you use these kind of situations or these kind of tricks to make sure that the child completely eats whatever they are given, okay, it leads to child overeating, and you tend to put the child in the overweight or obese category in the future. Okay. So naturally, just follow the children's flow of their energy requirements. When they want more, they will ask for more. Don't try to force feed, or don't try to make sure that if you have given a larger portion, don't bribe them into completing it. That gives way to it will pave way for the child to create a habit of overeating. Okay. From all the food groups, children or from all the food groups, it is the foods are included: cereals, pulses, fruits, vegetables, milk, meat, eggs, fat, sugar. Okay, they all the food groups are included in the child's diet. Fruits and nuts can be added as well, specifically nuts, so that vitamin B complex requirements can be met, omega-3 fatty acids can be met. Okay. All the 5 basic food groups has to be covered on a daily basis. And also mothers or whoever is cooking at home, okay, they can encourage the child to participate in the cooking process or help the parents out in some cooking. For example, cleaning the fruits or vegetables. Don't allow them to play with fire or anything sharp. Apart from that, what else you can do? Introduction of the non-vegetarian food is completely the parents' decision at what age they want to introduce. In the weaning age itself, you can introduce non-vegetarian food. Okay, slowly you can introduce it in the form of soups and broth. Okay, first, and then slowly uh, tissue meat, and then slowly organ meats, like that. Eggs you can introduce to the child who is as young as 8 months old or 7 months old. Eggs are given. Okay. Quality and quantity adequacy should be maintained when it comes to the food proportion. Food should be of good quality. Try to incorporate as much as possible organic food. Okay, organic food. Don't go for too much of frozen food or packaged food items. Good quality food items has to be given a predominance as compared to other artificial food substances, artificially flavored food. Okay, that those things has to be avoided. Proper elimination, that is, if there is a child passing the motion on a regular basis, does the child has a schedule for elimination, okay, using the bathroom, loo, etc., that has to be noted. And any issues with diarrhea, frequent diarrheas or constipation, okay, these has to be addressed. Pediatrician has to be involved if there is something troubling the child constantly, twice a week or so, that if the child complains of stomach ache, you see, look into it if it is related to constipation or any gastroenteritis, because certain food intolerances and food sensitivities can also give frequent occurrences of stomach aches as well. So keep a track on what all things the child has eaten. Okay. If the toddler does not have an appetite, there are certain syrups that the pediatricians can suggest only under clinical guidelines. Please take these syrups, okay, which induces appetite in the child. Okay. Variety, and the food has to be interesting and attractive, colorful. If you add more colors into the food, don't give them the same monotone food like khichdi. If you take khichdi for example, it's a monotone food item, okay? But when you put the but when you arrange the food in the plate in such a way that there is a lot of colors going on, okay, lots of things, lots of variety which is present in the on the thali, okay, that the child feel attracted to, okay. Apart from that, some other guidelines which we can discuss. Food intake of the children is more as soon as they find that the food seems interesting and attractive. That is too much. When you, for example, making chapatis in different color. You if you add beetroot puree into the chapati flour or atta that you have, the dough that you have prepared. Okay, it will give you pink chapatis. If you add some spinach puree to it, it will give you green chapatis. Okay, if you add some turmeric or papayas into it, it will make it yellow colored chapati. So if you provide them this colorful kind of food, try to use the make use of naturally pigmented food like beetroots, etc. on a daily basis. The child will automatically find an attraction towards these kind of food items. And also the food has to be slightly seasoned. Don't use too much of tempering or spices, okay, because too much of tempering or spices will lead to gastric inadequacy in kids, okay. Little bit seasoning is fine because that will make the smell tempting, and also the child should never be forced to eat more than what the child can take, because as parents are aware exactly what is the correct portion for their child, okay. So don't try to force feed them more than that. Always give them the same portion and wait for the child to ask for more, okay. If the child is asking for more, only then you can give more portion, but start with the baseline portion which you know is adequate enough for the child. But if the child is hungry, wants more, wants to indulge more, the child should ask for it, okay. So try to encourage the habit of asking for food in the child's feeding pattern. And also the person who is feeding the child should not show any dislike for any kind of food in front of the child, because the children have this habit of mimicking their elders, mimicking their parents, even though they do not have any issue with the food. But as soon as they see that their elders or their caretakers are avoiding certain food, they will try to mimic it. If they do not like a specific kind of food, try to mix it with their favorite food, what they like, so that the nutrient benefits is there. What kind of food the child prefers, okay, the child's preferences, the choices should be given priority. And regular meals, putting the child on a schedule, okay, not on a very strict schedule, but around that half an hour or 1 hour around the proper schedule. Feeding has to be encouraged to put them into a rhythm. And do not try to distract the child while the child is having food with TV, smartphones, computer. Okay, these things has to be turned off. Make sure that the child has their focus on what they're eating. They are aware of what they're eating. Water should be given frequently, because children, even though they are thirsty, they don't register it as thirst. Okay, specifically preschoolers, they don't register thirst. Okay, there are high chances that they will stay dehydrated. So encourage that they have water at regular intervals. Curd can be given so that the incidence of diarrhea or constipation or cold can be reduced. Unripe banana or unripe apple should not be given, because that could lead to choking hazards or chewing issues. And when you are giving your children any bite-sized part of any food, okay, an adult supervision should be there. It could lead to some choking issues, etc. Next, coming to the feeding problems commonly seen in preschoolers. First is dental decay. It can be caused because of, not just because of the child is having too much of sugary food, also if the child is deficient in calcium, phosphorus, and vitamin D, it could lead to dental decay as well. And also vitamin C deficiency could also lead to some dental issues. Whenever the fermentable carbohydrate sticks to the teeth, and when the child does not brush properly or does not rinses the mouth, kids do not have the habit of rinsing the mouth after eating something. Okay, they just after finishing their meal, they will directly go to play or something. So encourage this habit in the children, that they have to rinse the mouth after every time after they have had or they eat something. Okay, so that fermented carbohydrates can be taken away. There is no issue in giving coconut water to kids. There is no issue in, like, there is no research like myth or research behind for not giving coconut water to kids, specifically when it comes to dehydration. And whenever the child is suffering from diarrhea, giving them coconut water is an ideal thing. Okay, it is much better than fruit juices. Fruit juices have a lot of calories also in them. It is more sugary as well. Okay, but coconut water is a much better option for dehydration and thirst. Okay, coconut water is a really good option as compared to fruit juices. And also, whenever they have any stickier uh, chocolates, okay, some sticky chocolates, it's encourage them to rinse their mouth properly. Intake of sodas, too much of juices, sweets, that can also increase the calories along with the risk of having dental decays. Cheese, indulgence in overindulgence in cheese, it will also increase the pH in the mouth. That will also lead to decays. Next is pica. So this it is a eating disorder in which children want to eat non-nutrient or non-ingestible substances like any plaster, charcoal, clay, wood, ashes, metal, paint, kerosene, earth, mud. Okay, the mud that is wet, etc. Kids have the habit of eating this or munching on this. There are certain psychological theories of pica as well. There is an evidence that if there is any mental deprivation, okay, high frequency of maternal and parental deprivation, parents are not there with the child is left with grandparents or other caretakers, and if both the parents are working, the child is not getting adequate amount of attention. Okay, family disorganization, low socioeconomic status, deficiencies, nutritional deficiencies. Okay, these are the theories that are associated with pica. And if the parents don't supervise the child on this, and if the child still ingests all these non-essential, non-nutrient items, there is a risk of poisoning, okay, iron deficiency, parasitic infections, because if the child is eating mud, there are high chances the child may get any parasitic infection. Coconut water on a daily basis, nobody will give the child. Okay, on a daily basis, if you are giving, that would be another issue, but otherwise the coconut water is completely fine. Okay, specifically to treat dehydration and thirst. And feeding disorders, children who are not consistently hungry at meals times, they end up eating after meal time, and they end up either overeating or under eating. Both can lead to some health concerns. Okay, eating could lead to deficiencies, malnourishment. Overeating could lead to obesity or overweight issues. Absence of thirst mechanism, dysphagia, that is difficulty in swallowing, refusing the food, self-feeding inadequacy. The child does not does not like to eat food alone. He has a habit of somebody always feeding them. Okay. Food refusal by volume. As soon as they see too much of things are there on the plate on the child serving, they completely shut down. They don't want it anymore. Excessive meal duration, choking, okay, gagging or emesis, that is increased frequency of vomiting. Inappropriate meal time, okay, food selectivity and type and texture. People, some kids have this tantrums, okay, this kind of, they want either a slushed version, smoothie version of food. They will not eat solid food. Okay, they have certain tantrums. Every child is very subjective in that matter. Picky eaters. So there are certain symptoms of a picky eater. They accept only limited amount of food from the given choices. They are unwilling to try new food. They avoid some food groups completely, and the most common food group that is avoided is the vegetables. They exhibit strong food preferences, including presentation and preparation styles. They want, like some kids have this tantrum of eating food in a specific plate, in a specific shape. Okay, and they have this specificities that the parents have to follow, otherwise they will not eat the food. Okay, so those comes under the picky eating category. And it is a very common childhood behavior. Most of the kids, 90% of the kids do tend to be picky eaters. So how can you tackle such situation? Picky eaters should be encouraged to eat along with adults. Okay, to whatever meal they are having, it is recommended that they eat with someone who is an adult. And eating habits are taught better by example than explaining. You yourself as a parent or a caretaker, you yourself has to indulge in eating healthy eating habits. Looking at that, the child can mimic it. Okay. It is very common to see that the mother usually offers quick bites when the child refuses to eat meals, because the mother may be tired or she does not want to be part of any tantrum. Okay, she will just give a quick bite, whatever the child will ask for, like junk food, etc. And like she may try to substitute some snacks with meals, which is not a healthy practice. Small portion of food should be given at intervals. Don't try to overfeed the child within one go, in one meal. Small, frequent meals with small portion sizes can be given. So it will encourage hunger as well, the child asking for food. And even if the child is skipping a meal for a day, the child had breakfast, the child had dinner, but skipping the lunch, okay, it's not an issue. The mothers has to understand that it is not an issue if the child feels like skipping an entire meal. Coming to the nutritional assessment, anthropometric assessment, one of the anthropometric assessment is the mid-arm circumference. You can see here in both the images which I have shown, this is a healthy child, and the mid-arm circumference, you have to first take the length of the arm from shoulder to elbow, whatever is the length, divided by 2. Okay, in that particular length, you have to take the circumference of the mid-arm. That is how mid-arm circumference is taken. If the number is equal to or more than 11, then the child is healthy. Okay, when you do mid-arm circumference. If the number is less than 11, it means the child is malnourished. This is the very easy method to do the mid-arm assessment in preschoolers to understand their level of nourishment. Coming to the nutritional problems in India, first is obesity. Children specifically who are overfed by mothers due to wrong perception that the healthy child is considered as an obese child. Okay, that is a notion, common notion people have, even now people have in rural areas. Okay, anyone, not just the children, any person who is considered to be a bit chubby, healthy or overweight, people automatically go into the nation that they come from a well-to-do family or they come from a wealthy family. So just to create that notion, mothers tend to overfeed the child just for their family status. Okay, these situations do take place as well. Mothers, when they force feed the child with high calorie food like processed food, sweets, ghee, okay, and other any other farsons, etc., what they make at home, these are the habits that could lead to obesity in children. And as mentioned, this obesity can continue way into the adult life and teenage life as well, because the number of adipose tissues and fat tissues, if it increases during this particular age group, these fat tissues or fat cells will not disappear. Okay, it will stay there for more fat to be accumulated. Okay. Then we have PEM. Anyone who knows the full form of PEM? Some time ago, we had took a class on this. Is the video visible to all, or is the video not visible? Yeah, protein energy malnutrition. Protein energy malnutrition. It means there is a deficiency of protein. Along with that, there is a deficiency of energy requirements as well. The child is not fed properly. Okay, and specifically, the diet is very poor in protein. Also, protein energy malnutrition is is under the SAM category. SAM stands for severe acute malnutrition. Okay, and there are few types of severe acute malnutrition: kwashiorkor, marasmic kwashiorkor. These are the three different types of severe acute malnutrition. So in like basically the child is quite low in weight when it comes to the height. With respect to their height, the child is quite low in weight. Okay, and it is commonly seen, this PEM is commonly seen in low socioeconomic status families or economic groups. Okay, in these groups, and also developing countries and underdeveloped countries like certain of African countries. Okay, these kind of disease conditions are very commonly seen in children. So kwashiorkor and marasmus. In kwashiorkor, you can look at the images given here. It is identify that kwashiorkor is for a child who comes under 4, 5, 6 years old category, because it means older child. Kwashiorkor means older child. It's in African language. Okay, so in that you will see swelling, swollen lips, legs, edematous legs, sparse hair, moon face, because swelling is there on the face as well. So it tends to make the child's face rounder. So moon face with little interest in the surrounding. The child is distracted easily. Okay, flaky appearance of the skin, swollen abdomen. Abdomen is protruded. There is a accumulation of fluid in the it is called ascites as well. Okay, fluid accumulation in the peritoneal region, and then thin muscles, but fat is present. Okay, so here fat metabolism is not compromised, only protein and energy metabolism is compromised. In marasmus, normal hair, old man kind of a wizened appearance, because a child goes into the opposite stage of edema, that is severe malnutrition. So child has this wrinkled skin, sunken skin way into the skeletal structure. So it gives the child old man kind of an appearance. Thin limbs with little muscle or fat. Muscle, which means protein metabolism, and fat metabolism is the body goes into the state of catabolism protein and fat, and very underweight for the body height. Whatever is the child's height or length, based on that, the child is quite on a extremely low underweight category. So treatment, kwashiorkor as well as marasmus will be treated only in hospital setups. Okay, in no other facility or setup, kwashiorkor or marasmus has to be treated. It is only treated in the hospital or any clinical center. Dietary management, it includes giving the child formula diets. Can anyone remember what is the formula diet which we provide in the treatment of kwashiorkor and marasmus? Anyone? If you remember, what formulas do we feed as a part of dietary management of kwashiorkor and marasmus? Yes, F75 and F100. Formula 75 and formula 100. Okay. So in the dietary management, your formula, you have to start with formula 7 and then move on to formula 100. Okay. For a week or so, formula 7 has to be followed, and slowly you can move on to 100, formula 100. What is formula 75, 7 and formula 100? In detail, we will discuss when the chapter comes in. So, according to WHO, 10 steps are given for the recovery of malnourished child. Okay, we will see this in detail when the chapter arrives about diet therapy, and also about severe acute malnutrition. When we go to the chapter of severe acute malnutrition, we will discuss this in detail. Okay, formula 75 and formula 100. So 75 and 100, why this name came? Because every package of this formula 75 will give only 75 kilocalories. Formula 100, F100 will give 100 kilocalories. Okay, so that is the reason why these names have come in. This is how it is named. Okay. What are the contents of formula 75 and 100? It is given in the textbook of nutrition science. When we will discuss on the chapter of severe acute malnutrition in detail, we will discuss about the concept of these two formula diets. So clinical management will take place in two phases: initial stabilization and rehabilitation. In initial stabilization, the first thing you do is you admit the child in the ICU. Okay, and in the ICU, the child's hypothermia, hypoglycemia, okay, these kind of fatal situation, the child's body, when you touch the kwashiorkor child or a marasmic child, specifically the marasmic child, the child's body is very cold. Okay, so the child may go into a state of hypothermia, which is fatal. Okay, to make sure that the child is elevated out of the life-threatening condition, for the first week or first few days, the child will be kept in ICU. Okay, that is the first treatment. Initial stabilization, the first treatment is ICU care, and slowly the child will be, when the child is out of danger, when the glycemic levels are normal, okay, blood glucose levels are normal, and the child is free of any infection, hypoglycemia has been treated, hypothermia has been treated, the child is able to keep up the body temperature on its own. Okay, in such situation, the child will be moved out of the ICU into the ward, and the remaining formula, introduction of formula 75, introduction of formula 100 as a dietary management will start in the general ward. But when the child is in ICU, usually feeding is mostly done by IV fluids. Okay, the child is extremely dehydrated and all, so feeding is usually based completely on IV fluids. So rehabilitation, this is where rehabilitation takes place in OPD along with the wards. Yeah, vitamin A prophylaxis is given in the first initial phase. At the day when the child arrives in the ICU, vitamin A will be given. Okay. Depends on the age of the child. If the child is below 6 months, the child is below 1 year, child is below 2 years, below 5 years. Okay, based on the age of the child, there is a specific national level guideline which we have to follow. All the children who come under 6 months of age, 50,000 international unit is given. Under 1 year of age, 1 lakh international unit is given. Okay, the day when the child reaches the ICU, gets admitted, that day itself, vitamin A prophylaxis will begin. Okay. So rehabilitation, again, it takes place in the ward. First, the child will be put on Formula 75 diet, then slowly it will be tapered and Formula 100 will be introduced. And after that, regular food will be introduced with more bulk in the food. Whatever food the parents prepare, okay, it will be introduced in bulk. Okay, a little bit more ghee is added into the curries or into the serving. The child is helped out with one more pour of ghee or any other food, for instance. Portion sizes are increased slowly, not abruptly. Slowly the portion sizes will increase. So is it clear about the treatment of kwashiorkor or marasmus or SAM in general? Is it clear to all the treatment? Prevention strategy, it is health education mostly. FAO, that is Food and Agricultural Organization, WHO, Nutrition Expert Committee, they all have come with various national level and international level guidelines and policies which promotes the health, okay, of the women, pregnant women, lactating women, and mothers as well, mothers of a child who is under 5. Okay, we also have under 5 child development programs as well. Okay, under 5 child development programs are there, which targets the mothers of kids who are under 5 years of age. Development of low cost weaning food. Ragi is the best option for it. Okay, sprouted ragi, not the regular ragi. You sprout the ragi, you dry it, and you make a powder of it, and then feed it to the children on a regular basis up till the age of 2 or 3. Okay, it's really good for calcium, other minerals. Okay, iron as well. Measures to improve the family diet, health education to the parents, nutritional education to the pregnant women, lactating women, correcting the myths and beliefs systems, and health economics, how much money they have to save just for health, and family planning and spacing of birth, very important. Having adequate space of at least 2.5 to 3 years between two pregnancies. Improving the family environment, they all come under the health promotion category. Specific protection, the child's diet must contain protein and energy food items so that this particular situation will not arise again. PEM will not come again. Okay, so focus more on protein and the energy part in the food, like adding more milk, egg, fresh foods, etc. If it is possible, if it is affordable by them, encourage them to add this. Immunization schedule has to be followed up till the age of 16. Up till 5 year, when the child is 5 year of age, you have to follow regular immunization schedule. Then at the age of 10, and then at the age of 16. Food fortification strategies taken up by the government is also quite helpful. Specifically, fortifying the food that the government knows that it is going to reach the masses. Rich, power, whatever is your economic status, doesn't matter. For example, yesterday we have seen about salt. Salt is something that everyone uses. So fortifying salt is one of the way through which you can improve the nutritional issues. Okay, solvable nutritional issues among the population. Early diagnosis and treatment, periodic surveillance, mother card, mother and child card, Thai card, I card. Okay, these kind of cards are given from the PHC, and because of this this card, the child's entire milestones is charted by the primary healthcare worker, or by the mother herself can also chart, and bringing this chart along for your pediatric hospital visits will be also very helpful. Early diagnosis of any lag in growth, early diagnosis and treatment of infections and diarrhea. Okay, these all things should be taken care of as well. Next is deficiency of vitamin A. So some of the image you may find it very difficult to look at. You can stop the screen for that. If anyone who is not from a medical background, if you find it uncomfortable, so you can just listen to the presentation. So, according to the National Nutrition Monitoring Bureau, NNB, and Integrated Child Development Services Scheme, ICDS, it is said that phytoid spot, you can see here the third stage of xerophthalmia or third stage of deficiency of vitamin A. In phytoid spot, you can see a small chalk-like spot that is seen on the pupil of the eyes. Okay, it is chalky in nature. It looks like a pus. It looks like a chalk. Okay, mattified. Okay, it's not glossy. It is not at all glossy. It is mattified. Okay, so if you can see here in the second image, you can see a phytoid spot eye. So majority, a lot of prevalence is there in this particular stage. Okay, which is not just night blindness or conjunctival xerosis. It is a third part, that is phytospores. This all night blindness, conjunctival xerosis is one after the other. Okay, it's the deficiency of vitamin A will start as night blindness or blurring of vision. In night blindness, you are not able to your rod cells and corn cells are not able to perceive the image at night or in dark. Okay, not just at night, but even in dark, the perception reduces, your eyes perception reduces. That is night blindness. It starts with night blindness. Slowly, if the deficiency still continues, it goes into the stage of conjunctival xerosis. Okay, in conjunctival xerosis, dry patches of non-wettable conjunctiva, it appears very matte in texture. Okay, that is seen, and dryness of the entire conjunctiva is also seen. Usually, if you look at your eyes in the mirror, okay, you turn here and there, you will see that there's a glossy finish. Your eyes can shine back. Okay, but in conjunctival xerosis, that shine and the gloss is reduced. It becomes mattified. And in some cases, it becomes wrinkly and pigmented as well. But we will discuss about the vitamin A chapter in detail, specifically the deficiency part. All these classification of xerophthalmia, we will discuss them in detail there as well. Next is the phytoid spot here, the third stage. So these spots are raised. In conjunctival xerosis, it is the plane is not raised. It is the level of your conjunctiva as well. In phytoid spot, it is raised, and it may cause some itchiness as well. It may cause discomfort as well. These patches. It is a typical symptom of vitamin A. Then you have corneal xerosis. So when this dryness, which we were talking about, it was only here in the white part of the eye, in the conjunctiva. As soon as this xerosis or dryness will spread into the pupil of the eyes, you can see here in the third image. That's when you say it is corneal xerosis. Okay, the entire eye will become lackluster. It will lose its glossy appearance. Okay, and because of keratinization means what? Drying up. Okay, dryness and becoming hard and dry. Okay, no, it is not soft. When you see your dry skin, when you get a wound or something, okay, you see the wound drying up. Okay, that is a keratinized tissue, keratinized cells. So this is the characteristic feature of loss of substance or erosion parts of the whole corneal thickness. Here, if it is properly managed, the corneal changes can usually heal. Okay, but it will leave only certain useful vision. The vision will not completely come back. You can definitely heal from this. You will have a bit of vision as well, but it will not completely come back to normal. Okay, in corneal xerosis. Then we have keratomalacia or corneal ulceration. It is the fifth stage. In this, which you can see the complete pupil, it will become dissoluted into the conjunctiva. Usually, when you look at your eyes, you can see a proper demarcation. Yeah, it can be seen in children and adults too. Okay, those who are deficient, those who are malnourished, extreme cases of deficiency, this can be seen. In keratomalacia, as I was saying, the entire pupil becomes distributed into the cornea. Otherwise, when you look at your eyes, there is a proper demarcation between the pupil of the eyes and the conjunctiva of the eyes. Okay, here that demarcation will starts to blur. It means the pupil is becoming softened and it is getting soluble into the cornea. And if this process is not stopped by treatment, perforation of the cornea will take place, and it will lead to the complete loss of vision, total blindness. Then corneal ulceration or corneal scar. Here, complete loss of vision has already taken place. It's already took place, and there is no coming back from here. Xerophthalmic fundus as well. Here also, scar formation has formed. Complete loss of vision has took place, and there is no coming back to normal from the last two stages, last three stages. Okay. In corneal cirrhosis, treatment can help you stop this process, but the vision will never go back to the normal. Okay. So this is the classification of xerophthalmia. Is it clear to all? Xerophthalmia is the deficiency of vitamin A. Starts with night blindness. Night blindness is the first stage. Is it clear to all? All the other details of vitamin A, the etiology, deficiency, social factors, there's an entire chapter for vitamin A, 2 chapters for vitamin A. We will discuss that in detail later. Okay. Even the classification will come back again. So this is important. This knowledge is important for you. The treatment of xerophthalmia. This is also a national prophylaxis program for the prevention of blindness due to vitamin deficiency. Yeah, you have to, for your practical purpose, for your knowledge purpose, you have to remember it. Questions can come as well. Questions can come as well regarding this particular table. It is very important from practical point of view also. It is very important. Okay, this knowledge is very important. India is still fighting with we have one national program in India for the prevention of blindness, specifically which is caused by deficiency. Okay, any blindness that is caused by birth, okay, or due to any traumatic injuries, accidents that you can't help out. But just because of the deficiency of food, not having a nutritive food, and the population is going blind, that is something that is a major concern for the government as well. Okay. So we have a national prophylaxis program for vitamin A prophylaxis. So immediately on diagnosis, 1 lakh international units of vitamin A in the syrup form is given to a child who is less than 1 year of age. If the child is more than 1 year of age, 2 lakh international units is given. You do not have to count it, because when it comes in a syrup bottle form, it comes in a specific spoon also. A spoon is given along with the syrup bottle, and the primary healthcare nurse knows how much, what amount of syrup has to be given to the patients who have come based on their age group. It's usually, if it is half a teaspoon, tablespoon, half spoon, it means 1 lakh international unit. If it is one entire spoon, it means 2 lakh. Okay, spoon size and shape can also differ, but the packaging in which it comes, it is written 1 whole spoon means how many international units you are giving. Okay. The very next day, the same dosage has to be continued for 2 to 4 weeks until and unless a normal serum vitamin A level is established. You have to continue the same dosage. And when the child comes with severe acute malnutrition or protein energy malnutrition, and monthly until the child is completely reformed and cured of energy malnutrition, the same dosage has to be followed. Okay. 1 lakh international units for all children who are under the age of 1, 2 lakh international units for everyone who is above 1 year old. Okay. It is very easy to remember. And how long it will go? As long as the vitamin A status becomes normal in the blood serum levels. Immediately on diagnosis, it has to be given. It should not be delayed. And in injection form also it is given. Okay. Intramuscular injection of 1 lakh international unit, which is water soluble. Okay. In the form of water miscible is given to patients who come in with deficiency as well. So oral and intramuscular forms of treatment is available for vitamin A prophylaxis. Under the Maternal and Child Health Services and ICDS program, this vitamin A administration is recorded. So this is our national prophylaxis program for the prevention of night blindness, which specifically has a very important place for vitamin A cure or deficiency management as well. So this is also another important table. I'm not sure if the textbook has this table or not. I guess they have not given this table. They've only given the table for xerophthalmia, but it is more or less very similar. So vitamin A solution in a pre-calibrated measuring scoop or spoon. This is what I was mentioning. The syrup, yeah, if it is not present in the textbook, please take a screenshot of the slide, okay? This is what our national prophylaxis program is, which is in India, okay? So yeah, it comes in a syrup bottle and a specific spoon. So preference in India, children who are 9 to 36 month, 2 times in a year, this has to be given. Children who are up to 12 months, that is 1 year, less than 1 year of age, same 1 lakh international unit is given. So 1 ml is given, that is half a spoon. Okay, and sometimes it may change. Okay, don't just go by this 1 ml half a spoon, because sometimes the spoon size and shape it may change, and based on the packaging, based on the instructions written on the packaging, you have to follow the guidelines. Okay, so same thing, if the child is less than 1 year of age, 6 to 12 months means less than 1 year of age, 1 lakh international unit. And at the 6th month also, as soon as the child turns 6 months old, as a universal immunization schedule, as a part of it, vitamin A prophylaxis is also given. Okay, when the child comes for immunization at the age of 6 months, this syrup is given. And when the child is more than 1 year of age, 2 lakh international unit is given, that is 2 ml, one entire spoon. And different age at what when the dose has to be given is mentioned here. At 1 year, 1.5 year, 2 years, and so on. These are the time periods when the parents have to take the child to the hospital. So every 6 months, you have to take the child to the PHC or CHC and get this dosage given. Okay, it applies to all the healthy children. It applies to every healthy child, deficient or not deficient. And for postnatal women, also 2 ml is given within 45 days from the date of delivery. When the mother comes with the child after her puerperium is over, puerperium is a 42 days long period. As soon as she has given birth, the mother has given birth, from that day onwards, 42 days or 45 days is considered as the puerperium period, when the mother's body is recovering the most after pregnancy. Okay, as soon as the first 45 days is done, within that time period, mothers also should receive the vitamin A prophylaxis. Is the table clear to all? And this is a part of our MCH and ICDS program. Okay, since the postnatal women are involved here, that's the reason why it is a part of the Maternal and Child Health Services program. So feeding programs in India. So the ICDS feeding program, that is the Integrated Child Health Services feeding program. What you see on the screen is just a snapshot of the things that they do. Okay, supplementary nutrition. When we come across the various nutrition of lactating women, pregnant women, infants, preschool children, adolescents, okay, you must have come across ICDS everywhere in this chapter. So they are involved in the supplementary nutrition. They have specific packaged food which is ready to eat, or they just have to take it to home, mix it with water, or mix it with milk and have it. Okay, so these are supplementary nutrition. So do not confuse supplementary nutrition with meals. Okay, whatever supplementary nutrition in Anganwadis, through Anganwadis or PHCs, pregnant mothers, lactating mothers, okay, play school children are getting, the supplementary nutrition means they are not the substitute of meal. Meal should be there, balanced meal should be there. This is just an add-on. Okay, immunization, the universal immunization schedule is followed by the funding of it. Okay, it's taken care by the ICDS scheme as well. Preschool education, that is Anganwadi. Okay, Anganwadi in India is the preschool education, is also taken care. The funding of it is done by ICDS as well, along with the government ministries. Health checkups, free health checkups, health and nutrition education for lactating mothers, teenage girls, adolescents, pregnant mothers. Referral services whenever there is a complication, any high risk pregnancies and all, in case of complications, referral services. Any high risk child rearing process or children born with special needs and all. Okay, for them also referral services to better institutions is also given by the ICDS. Next, we have the midday meal program. Any guesses which state in India started the midday meal program? Any guesses? Yeah, it was started in Tamil Nadu. And seeing the success of midday meal program, okay, how well it was taken care of, how well nourished, what kind of nourishment it brought to young kids. This happened in the 1960s, okay, 1960s or 1970s, that particular decade. Midday meal program was introduced in the state of Tamil Nadu in all the government and the public schools. And seeing its impact, seeing its success, the kind of attendance it brought into the state, the literacy rate of the state increased. Looking at that, the midday meal program was adopted by the entire country. Okay, in all the government schools, public schools, midday meal program is still practiced. Okay, and there are certain concepts in midday meal program which has to be followed, which means whatever food that you give in midday meal program. For example, if you take the state of Madhya Pradesh and if you take the state of Maharashtra, okay, the recipes that you find in midday meal program is not universal to all the states of India. It is very important for the success of the midday meal that the staple diet is used. Whatever is the state's staple food, whatever is grown locally, okay, local farmer markets, local agricultural lands, okay, and in majority of the cases, school gardens. Students are encouraged to plant eatable things in the school gardens, and that is used in the midday meal as well. Okay, so it gives kind of an encouragement for the children to replicate the same habit, having their own kitchen garden, knowing gardening, knowing plantation. Okay, basics of plantation and gardening, basics of food rearing. These kind of knowledge is important to the kids. They practice. They will practice this at home as well. Okay, and in midday meal programs also, the vegetables and fruits can be used from the same school kitchen garden. Okay, and it is very important that staple food has to be given, because that is cost effective, economic. Okay, so the funding of the midday meal program will not be much of a burden for the state governments as well. Okay, so usually, more or less, this is what the menu plan for a midday meal should look like. Cereals, 100 grams for primary classes in one meal, 500 grams for upper primary classes. This is raw, okay, not the cooked one, raw. Pulses, 20 grams for primary classes, 30 grams for upper primary classes. Vegetables, 50-75 grams respectively. Oils and fat, 5 grams, 7.5 grams respectively. Okay, So this should be the basis of any midday meal program. Desserts, sweets, you can add more to it, but the basic pulse, cereals, vegetable, and fats should be covered. Okay, and protein is also covered. In certain states, eggs, boiled egg is given. In certain states, boiled eggs are not given. Okay, as a part of midday meal programs. So these are the benefits of the midday meal program. Means it increases the literacy rate, it increases the attendance of students, it will reduce the school dropouts. Okay, before 10th dropouts can be reduced, because just for the sake of having that one particular meal with the friends and classmates together. Okay, it's a very very happy, memorable environment for children growing in that age group. So it encourages children to sit in the class, and it's a midday meal means they have to cover the at least half of the school day, even if they're bunking after lunch. At least first half of the school hours are covered, and it imparts literacy in the population. Okay, attendance is kept on, and even female child education has been improved after midday meal program, which was incorporated, because in rural India, nutrition for the female child is not a point of focus. Okay, but the parents will send the daughters to school just to have their meal from the school, and they can come back. So because of that, literacy rate has improved, girls attendance at school have improved, and rogues and other silly behaviors in children have reduced. Okay, if they're not in the school, they are doing some kind of uh, addictive behavior, substance abuses, or some other criminal behaviors are taking place in teenagers and children somewhere else. Okay, so if they are in school, they are much more better monitored at least. Okay, so the crime rates can also fall over a period of time. So these all are the other benefits that midday meal program can bring into the society. Okay.